Hello and welcome. I'm Pat Lincourt. I am the Director of Practice Innovation and Care Management at OASAS. I'm here to introduce Dr. Steve Kipnis and Rob Picculel, who will be presenting on stabilization and withdrawal management in substance use disorder treatment. Steve Kipnis is a medical doctor who has many years of experience in treating addiction and particular experience in treating withdrawal. Rob Picculel is a social worker who has many years of experience also in treating and providing behavioral intervention for individuals in SUD treatment. Both of them are former OASAS employees and were involved very much in the thinking about ancillary withdrawal services in SUD treatment. So OASAS is in the process of implementing Medicaid redesign across the board, across our system. And one of the things that we want to accomplish is to be able to better integrate care for individuals and provide treatment for the full range of symptoms that people come to treatment with. And that includes medical intervention for withdrawal and stabilization of the individual in all treatment settings. So the vision that we have is that withdrawal treatment would be available to every patient no matter what door that they enter into in SUD treatment. The value that to the patient and to the program can't be overstated. Individuals who enter care and have some symptoms of withdrawal aren't available to be able to be engaged in treatment until that withdrawal subsides. So being able to assess and intervene early allows the program to engage that person into care and improves outcomes. That is also advantageous to the program dealing in a Medicaid managed care world, as managed care companies will look for those services, and the program will be of increased value to the managed care companies who are looking to have the full range of services and assessment available to patients. So that is the presentation that Rob and Steve will present is really about that rethinking about detox. Detox in general has been seen as something that somebody goes away to and then in a short time comes back out and may be engaged in treatment. To really being able to identify withdrawal across the entire spectrum that patients experience it, from very mild to very severe, assess it appropriately, and get the person the care that they need, including medication for managing the withdrawal symptoms. So, and then also looking at withdrawal over time. So sometimes people have symptoms of withdrawal that last over a period of weeks or even months, sometimes referred to as protracted withdrawal. So without further ado, I'm going to introduce Dr. Kipnis and Rob Picculel to talk about stabilization and withdrawal services.
Welcome. I'm Steve Kipnis.
I'm Rob Picculel.
I was the former medical director for New York State OASIS and am an addictionologist.
And I'm a social worker, and Steve and I worked for a number of years trying to rethink detox.
When you look at withdrawal, it really is the change in receptor function of the brain, particularly in the reward center. The reward center of the brain is an area that is filled with dopamine, and it's meant to help you learn behaviors. So if you drink water, you'll get a little burst of dopamine, and you'll learn that water is good to drink and to keep you alive. Unfortunately, alcohol and drugs gives you a bigger burst of dopamine, and the reward center quickly learns that this is a pretty good way of getting dopamine. When you take away the alcohol and the drugs, the brain has to try to reset itself, and this is really the withdrawal stage. It is partially receptor overload by non-inhibited neurotransmitters, partially just the brain just trying to get back to square one.
And those changes in the biochemistry of the brain affect behavior. It makes a difference in how somebody is going to interact with you, how they're going to feel, how they're going to perceive things.
And that's one of the keys of this entire webinar, is really not to teach you all there is to know about withdrawal, but really to have you understand that withdrawal affects how the patient is going to deal with your program and be able to do what you want them to do and cooperate. One of the pearls of addiction medicine is that withdrawal is always the opposite of what you see when someone's intoxicated with that drug. So if you use a sedative, it'll knock you down. In the withdrawal, you get signs and symptoms of excitability. Some drugs produce really significant physical withdrawals, such as opiates and alcohol. Some drugs produce very little physical withdrawal, but a lot of emotional withdrawal, and you see that in the stimulants and marijuana. The key is that every person's physical and actually emotional withdrawal is different, so that you can't put everyone into the same box. Some experience little physical withdrawal, some experience a lot.
And what you'll find is that as people withdraw from it, it does affect their behavior. It does affect their mood. So you're going to see depression, you're going to see anxiety, you're going to see sleeplessness, and that this is a symptomology that directly impacts somebody's ability to engage in care. So we're really talking about rethinking detox. And what we try to impress people with is that we don't want you to think of detox. We want you to think of stabilization and engagement. That what we're looking to do is make the patient comfortable, not make them more anxious, more depressed, more in withdrawal, but really to get them stabilized and comfortable, and do that as part of a medical regimen. That it would be conducted under the supervision of a physician. And this is, in many cases, a change in the role of the physician in our treatment facilities, to have them be more actively engaged in medicating the symptomology that patients were presenting and stabilizing them when they first came into care. And we thought that with that stabilization, that patients would be more amenable to engaging in treatment, present less difficulty in dealing with other patients and in dealing with the staff, and really the expectation is remain in care a longer period of time. And the research shows that the longer patients stay in care, the better the outcomes tend to be.
The drug-specific features of withdrawal are different depending on which drug you decide to withdraw from.
Alcohol, opiates, and sedatives
tend to be really lend themselves to nice slow tapering, particularly the sedatives. It's very difficult to detox someone from long-term sedative use in 3 to 5 days. It's really dangerous. So over weeks or months, it's actually a much safer way to go. Alcohol and sedative dependence, if you see withdrawal, could be life-threatening. Opiate dependence, on the other hand, if you see withdrawal, the patient will feel doomed. They will feel like they were going to die. But the beauty of it is no one has ever died of opiate withdrawal. So it makes for a safer drug to detox from as an outpatient.
And while we would say that nobody ever has died from an opiate withdrawal, many patients experience this as they would like to die from it, that it is very excruciating and very prolonged in many cases.
Yeah, exactly true. And the opiate withdrawal patient is using opiates at that point in time to prevent withdrawal. They're not using them to be high anymore. So it's a different mindset that you have to deal with. Some of the other drugs like the cannabinoids and the stimulants and the hallucinogens really give you a low level of physical withdrawal. They don't warrant hospitalization, and the withdrawal symptoms can be very easily treated in one of our ancillary stabilization withdrawal settings. The impact of withdrawal, what do you see when someone's going through withdrawal? What's the impact on the program?
Well, I think that one of the first things you want to do is you want to pay attention to the fact that they are having symptoms, that you want to look for and explore with the patient whether they're having a depression, whether they are sleepless, whether they are having anxiety, how this is affecting their life in general, and also their awareness that these things are happening to them.
So frequently when you walk through a program, you'll talk to counselors and nursing staff and even the physicians, and you hear somebody is a non-cooperative patient. And really you have to step back and say, is the patient being non-cooperative, or are they going through such bad withdrawal, even if it's low level, that they can't cooperate? Now, we realize that there is patient motivation that's important, and patient personality is important. But I think we always forget that the person's not really comfortable and can't do what we want them to do when we want them to do it.
So what we find is that the impact of withdrawal not only affects the patient, but it affects the interaction with the staff, with the physician. And these are things that we can address with medication and with behavioral therapies.
Right. We're going to go through some of the drugs and what kind of withdrawal you see, looking at it more from the patient perspective and what you see in a program as compared to the real just pure medical. So when you look at alcohol, there are different stages. Most times alcohol withdrawal starts 6 to 60 hours after your last use. You can sometimes see just minor withdrawal, which is some tremors, some insomnia, nausea, vomiting, a little anxiety and a little weakness. If you could catch a person at this stage, really very easy to treat with substitution therapy, meaning I give you my sedative for your sedative being alcohol. And we'll go to some of the protocols, but frequently you could use the phenobarbitals or the benzodiazepines for treatment. If the person is going through this minor withdrawal, they may have what's called an action tremor. Their attention span is incredibly limited, and they could have redness of the eyes, and really if you do reflex testing, they'll have increased reflexes. If you let the person go from minor withdrawal to severe withdrawal, now you start having significant medical issues. Mild withdrawal, easy to treat, usually you don't run into problems. Severe withdrawal has to be treated in an ICU setting, and you have unbelievable signs and symptom changes. The person has severe sweating and is losing an unbelievable amount of fluid. Bad tremors, elevated blood pressure, elevated pulse. But the main thing you look at is that they are totally confused. They don't know where, they're alert and they're awake, but they don't know where they are. Pretty scary for them and for you. The withdrawal from benzodiazepines are very similar to alcohol, though the key is it starts a little later, it's a little bit slower in the onset, and it lasts a little bit longer. But you see the same kind of things, psychological withdrawal, CNS effects, gastrointestinal effects. This is one of the other drugs besides alcohol where if you don't treat the withdrawal, the person could have a fatal outcome. And there are different stages of opiate withdrawal. The first stage, or early withdrawal, sometimes is referred to as everything is running. The nose is running, you're sweating, you're yawning, your eyes are running. Pretty uncomfortable for the patient. And as it progresses, if you let it progress, the person will have dilated pupils. Looking at pupils are the key to diagnosing opiate intoxication, where the pupils are really tiny, and opiate withdrawal, where the pupils are really, really dilated. Here, the person is very irritable. They don't want treatment. They just want to make themselves comfortable. Can't sleep, can't eat. And if you let it go, it just keeps escalating, where you get high heart rate, high blood pressure, nausea, vomiting, diarrhea, mood changes, depression, muscle pain, muscle weakness. And the beauty of this stage is you could actually treat each one of these symptoms with a PRN or as-needed medicine and make the person more comfortable. You give them back a little control with the PRN, where they could see when they have a symptom and then take the medicine that's appropriate to take care of that symptom.
So it seems as though you're saying that you really need to assess the patient accurately, and that once you've assessed them, sometimes over time, as the withdrawal starts to kick in, you may see a change in symptomology.
Yeah, the key is really to continue to assess the patient. As we said, everybody's a little bit different. It's very tricky, but you have to keep assessing, keep asking the patient how they're doing. Stimulant withdrawal really is like you have a hangover. You don't sleep, you're fatigued, you have headaches, your jaw may hurt. The key to this is really anxiety and depression. Again, not really being too interested in drug treatment, really just wanting to eat a little bit and to take a rest. Marijuana or cannabis withdrawal used to be thought that it didn't really exist. Now we know that it does. It occurs 10 hours after your last use and could last 5 to 7 days. Again, person is not really going to be the prime candidate. They're anxious, they have mental clouding, they don't sleep, they don't eat, they're depressed, they have headaches, sort of similar to pretty severe nicotine withdrawal. Again, if anyone's ever smoked and gone through withdrawal, if they tried to stop smoking, you're not really, the most amenable patient to anything. We put in anabolic steroids in this section for one reason only. A lot of people take patients on anabolic steroids, stop the steroids, and think that their job is done. And in fact, one of the findings in anabolic steroid withdrawal is severe depression that occurs 1 month, 2 months, 3 months after they've come off of the steroids. And several kids and adults have actually committed suicide in this stage, where the treatment provider thought they did all they had to do, and in fact, they didn't. Again, you get headaches, insomnia, very restless, very uncomfortable state that could last for a while. When I say it lasts for a while, that brings up protracted withdrawal. What do you think about when we talk about protracted withdrawal, and do programs actually think about this or not?
I think that very often our programs and our patients who have been through treatment a number of times have an expectation of what treatment is going to be about. And what we think can be enhanced is really starting to look at these withdrawal symptoms as a focus of care. That somebody's lack of sleep, somebody's anxiety, somebody's depression, that these are areas that we should be aware of and look for, that these are things that we should be educating patients about, and that we should be working with physicians for, where possible, a medication might ameliorate some of the symptoms, and a behavioral therapy could be utilized to help the patient work them through. I think that, once again, we're not just talking about withdrawal. What we're really talking about is stabilization. And that if you're able to stabilize the patient, that they're able to engage better in care. And sometimes these protracted withdrawals can last a very long time. If somebody were to break a leg, we would expect that they would have problems for a long time after the leg was set, after the leg was healed. And in fact, on a rainy day, a year later, they may still be having problems. We think that in some cases, with a chronic recurrent disease model, that you should be aware, and the patient should be educated to be aware of these changes in their behavior, be aware of these changes in their emotionality, and to make affirmative actions to address them, either with medications or with medications and behavioral therapy.
Yeah, it's pretty important points. The two keys for protracted withdrawal are sleep difficulties and depression, both of which are going to impact the person's recovery and really could be addressed fairly easily if one asks and thinks about it. So protracted withdrawal, a real problem that gets a lot of people out of treatment and out of their recovery.
So this is something that we think that programs can strengthen, that this is an issue where staff can be educated, staff can be given tools to address them, and certainly patients would benefit from being educated about what's happening to them, because these are challenges to their recovery.
And the beauty of the model that we're going to be telling you about, the ancillary stabilization and withdrawal, is really you could keep them in treatment, and detox is not treatment, but you could keep them in real treatment, treat their protracted withdrawal, keep them engaged, and have a successful outcome.
Hello again, and I want to say thank you to Rob and Steve for that excellent presentation on withdrawal and stabilization services. What they really emphasized in that presentation was person-centered care, the need to really listen to each individual patient as they enter into care. One of the things that Dr. Kipnis talked about was how each individual has a different experience, both physically and emotionally, of withdrawal, and the need to really listen to what they're experiencing, what they're telling you, and what they need in order to fit care to their unique presentation. I hope that you enjoyed this video. Please view the second in the series of withdrawal and stabilization, and thank you.